delighted to be again here as a moderator, courtesy Dr. Chauhan and his team, the Physician Forum of India. And it's a very, very special occasion, 850th CME continuous. Of course, the interruptions are no interruptions. They were all our compulsions to either COVID or some.
सर थोड़ा तेज बोलिए विजय थोड़ा वॉल्यूम चेंज करो सुनाई नहीं पड़ रहा
Okay, sir.
मेरे आ जाओ
Sir, is it better, sir? So it's my pious duty on the eve of Women Empowerment Bill to call a woman stalwart of nephrology in NCR, Dr. Alka Basin. I know her for at least 17 years. When I was attached to, I started my attachment with Max Panchit Park. And she is attached to Max services since inception of the Max services. It's close to 25 years. What a great experience she had with Max services, Max health services. Great, I would like my friends to clap for her for 25 years of association. I was told to be very brief in her introduction, and I honor that. She is MBBS, which is written MBCH, CH is Virology, Surgery from Ireland, MRCP from Ireland, and she is the main power with Max Sarkar and Max Smart behind the nephrology department. I call her for her
MRCP London.
I'll just request her to be brief in her presentation and give more time for interaction. Welcome, ma'am.
लाइट्स ये लाइट्स जरा ऑफ कर दो लाइट्स ऑफ कर दो सारे नहीं Can I just request everyone to please keep decorum during the meeting? It has taken me 5 years to bring Dr. Alka Basin to the forum today. It's been, I am telling you, it's been real hard work to get her. And it will be 10 years if you make noise today. So if you want to make sure that we get her back within a year, please give her full respect, keep the decorum, and keep your answers and question and answers ready in the end. You know, answers all by Dr. Alka Basin, questions none to me, please.
Great. Well, it is indeed a proud privilege for me to be present in the midst of such an elite gathering. And I'd like to start by thanking Dr. Chauhan for this wonderful opportunity. I've been wanting to come here for quite some time, and I think I last was in this forum about maybe 6-7 years ago. I'd also like to thank Dr. Kalra for the very kind introduction. And it's indeed an honor to go around the room and meet so many wonderful people, so privileged, doing so well in their respective fields. What I'm going to be talking about today are a few hand-picked cases that I have come across over the last 1 year. Thought I would just share our experience of these challenging cases with you. They have posed for us some diagnostic and some therapeutic dilemmas, and I think this is the best forum in which to discuss them. So let me begin without any further ado and take you through the cases. So the first case is a young boy, 19 years of age, from Siliguri, who came to Delhi with his parents seeking admission in college, first year college, after completing his class 12. He came last summer, and just to give you a bit of a background, because it was very astounding for me to sit with this guy for 45 minutes and take his history. You'll be surprised to see how a 19-year-old boy has been smoking 12 cigarettes a day for the last 3 years, smoking marijuana for 3 years, taking a banned drug called Spasmoproxivon, which contains dicyclomine, tramadol and paracetamol, multiple pills a day for many years, He's been ingesting large quantities of Corex cough syrup every week for the last 2 years. He's been taking whey protein powder after visiting the gym for the last 2 years on a daily basis. He's been taking a liter of Coke every single day. He's been a frequent user of red meat and has been eating very poorly for the last 2 years, losing weight, and has had frequent vomiting for the last year. So with this grim background, I'll tell you what exactly happened to him and why he came. 6 days before he met me in the OPD, he was out at the Vasant Kunj Mall with his friends. In the mall, the family tells us that he suddenly fell to the ground, lost complete consciousness for approximately 3 hours. The parents were alerted by the mall security, and instead of taking him to a hospital, they brought him back to their relative's house in Delhi, where he was nursed for his multiple bruises on face, neck and upper limbs. He came around after 2 days or so, and when he did come around, he was very dehydrated, not eating a thing. Copious vomiting was noted, and still the family did not bring him to any doctor. It was only when he started to pass urine, which was very, very scant in quantity and a deep brown color, that they got alerted, and that's when they came and saw him. On the day that he came to see me, he was alert, he was talking and giving this history. In front of his parents, he regurgitated all of his indulgences, but he had a complete amnesia of the event that took place in the mall. His BP was high, 160 by 100. His pulse rate was alright. He was weighing 68 kilograms, and there were extensive ecchymosis noted in the limbs. So at this point, my working diagnosis was a young male with an anuric ATN in the setting of a very prolonged state of dehydration, coupled with possible rhabdomyolysis because of the color of the urine and the fall that he had had. And with this, his BP was very high, or secondary hypertension. My other possible working diagnosis was that his anuric renal failure could be due to bilateral obstructive uropathy, and that this deep colored urine could actually be blood also. So gross hematuria with bilateral obstruction, and that the loss of consciousness needed adequate explanation. Had he had some intracranial pathology, had he had a seizure, all that needed to be investigated. So the first round of investigations was as follows. His hemoglobin was 13.8, TLC 14.9. Look at the urea, 180.4, creatinine of 10.5. These were OPD labs done on that same day, on that evening where we admitted him. His ABG showed metabolic acidosis with a pH of 7.31 and a bicarb of 19. He had a low sodium of 128, borderline high potassium, a low calcium of only 6.8, hyperphosphatemia, and look at his uric acid, 21. Vitamin D low, again metabolic acidosis, and look at this number. The total CPK was 4,21,000. And parallelly, the AST, ALT were also in the thousands. Albumin was low. His urine analysis had 15 to 20 red cells, 10 to 15 WBCs, and +2 for protein. So it was a mixed sediment. No diabetes, thyroid normal, and the urine culture came back sterile. So although he had pus cells and red blood cells, the urine culture was indeed sterile. His ultrasound showed bilateral nephromegaly. In other words, the kidneys were swollen, but there was no hydronephrosis. And his CT imaging on arrival was also not showing any acute intracranial pathology. So at this point, my working diagnosis was again anuric ATM in the setting of a very prolonged state of dehydration with confirmed rhabdomyolysis now, because as you can see, the CPK total, the AST and the ALT are all three indicators of muscle injury with secondary hypertension. So skeletal muscles were injured, and it was was likely that the patient had had a seizure, which was due to the substance abuse. The accelerated hypertension could have also triggered a hypertensive NCAP and seizure. Hypocalcemia, hyponatremia, uremia are all possible causes of this seizure. I felt he had vomiting due to severe uremic gastritis and prolonged dehydration leading to high uric acid of 21, and that this was further aggravating his acute kidney injury. Now the management of this young boy was in the indoor services. He was given aggressive intravenous hydration. To take care of this seizure possibility, we gave him IV levetiracetam. We corrected his electrolytes. We managed his accelerated hypertension, and we did give him a trial of loop diuretic. But unfortunately, he did not make urine. And at the end of 24 hours of medical trial, we had to do hemodialysis through internal jugular access. And over time, the CPK, AST and ALT, these muscle markers, all started to recede. We did give him a psychiatry evaluation because of his multiple addictions, and he was a had poor communication with both his parents. Nutritional counseling was provided because he had very poor appetite and a very poor dietary habit for 2 years. And overall, this boy did very well because we discharged him on day 7, still on dialysis, and he only needed a total of 7 dialysis sessions over a span of about 15 to 18 days. And after that, on OPD follow-up, we started to make urine and we withdrew the dialysis, and he was back in Siliguri doing very well with a normal creatinine of below 8, not requiring any further dialysis. This case highlights to you the menace of gym supplements. And over the last 2 years, I've come across multiple cases, usually young people between 18 and 35 years of age, who are frequently going to the gym, and they come to a nephrologist like me with some or the other renal parameter which is deranged. Some come to us with deranged creatinine, anywhere from 1 to 1.5 or 2 range. Some come to us with variable levels of proteinuria. Some have come to us with kidney stones. Some have come to us with accelerated hypertension, and some with a combination of all of these. And this is why I felt that it was very important to highlight this growing menace of gym supplements in a larger forum. Now the common thread in all of these young adults is that they go to the gym and they have a very high intake of dietary protein as well as gym supplements which contain whey protein powder. These whey protein huge big jars that you might see youngsters carrying around also contain caffeine and steroids in some proportion or the other, branched chain amino acids, creatine powder or creatine tablets. Cough syrups are being taken in abundance. They are also taking and indulging in growth hormone. To top it up, a lot of chicken, eggs and peanut butter at home. And let's not forget the alcohol and the nicotine and the marijuana on the side. Our young boy had been taking cough syrups and spasmoproximol also. So this alarming increase in the cases that are coming to nephrologists shows to you the harmful effects of this protein intoxication on the delicate kidney filters, coupled with those very high levels of blood pressure giving kidney injury. Now exactly what happens at the level of the kidney through these supplements? Caffeine and creatine are needed to promote endurance as far as the gym instructors go, and they enable a very high intensity workout, but they accelerate the heart rate, which gives this youngster a kick, and a high metabolic rate gets them through the rest of the exercise program. But when used in abundance, they also cause high blood pressure irreversibly. Many of these concoctions which contain whey protein also have BCAA and creatine within the same packaging. We must not forget that even the steroids that they are using are harmful, including substances like dexamethasone and testosterone, which are consumed to enhance their performance. They get an alcohol rush from the cough syrups that they take, and these youngsters find themselves getting puffy as they take the steroids. And when they get puffy, they start to use diuretics such as torsemide, such as spironolactone, so as to get an extracellular dehydration going, so that they get a very nice lean image and have a very good photogenic appearance for the the gym, these macho contests and competitions that are going on to show off their six-pack abs. And this is very, very, very important as far as the young teenagers are concerned. Unfortunately, with this high protein intake, plus the overuse of diuretics, they're getting into hyperuricemia and making more stones, and getting into problems such as gout at a very, very young age. And because they're doing so much exercise with their muscles and pumping them up, then the gym instructors have informed them to take a plethora of vitamins to keep the skeleton strong as well. So you'll see them indulging in calcium, vitamin D, vitamin C, omega fatty acids to support the bones, and many of them come intoxicated with these vitamins as well. So sorry. So it was in March of this year that I wrote this article which came in the Times of India on the occasion of World Kidney Day to alert the youngsters, their families, the gym instructors to try and rationalize the use of whey protein powder and all of these gym supplements so as to see some light at the end of the tunnel with these. And I think that greater regulations from the government are required on these supplements. We can have a discussion on this later, but I'll now move on to case number 2. The second case is a very interesting lady whose age is 81, and she was a non-diabetic, well-controlled, hypertensive lady from Gurgaon when I met her. She first presented in the month of March with microscopic hematuria detected on a routine test. And at that time, her creatinine was only 1.01, not too bad. But over the subsequent weeks, her microscopic hematuria did not go away on a subsequent bone analysis, with traces of protein and a creatinine which was going upwards to 1.4, 1.8 in just a matter of days. With that, her BP was shooting up to 200 by 115, and that is when we hospitalized her. She was having gross hematuria with lower limb edema. She was quite pale, with a hemoglobin of 9.3. And by now, this creatinine, which was just 1.01 a few days ago, had shot up to 3.8. She was making urine, but hematuria. Her ESR was above 100, which is an alert value. She was in metabolic acidosis, hyperkalemia, hypoproteinemia, and had +2 on the urine protein analysis. So how do you put this together? My working diagnosis was a rapidly progressive form of renal failure, or RPRF, with an active urinary sediment in an elderly lady with a very high ESR. And a very high ESR above 100, believe you me, has only 4 or 5 causes, no more than that. And of course, accelerated hypertension. With an active sediment like this and gross hematuria, I think some differentials do come to your mind as well. And we started with an ultrasound which showed swollen, bulky kidneys which were echogenic bilaterally. The kidney sizes were preserved and the CMD was partially lost. Interestingly, her anti-nuclear antibody, her connective tissue disease profile, her vasculitis profile with GBM and ANCA all came negative. So were her complements and her coagulation profile. We did a 24-hour urine collection to quantify this +2 protein, and we found 1.8 grams per day of proteinuria. CP angles were minimally blunted and heart function was alright. So at this point, with negative serologies, negative vasculitis workup, and gross hematuria, I labeled this as an acute, rapidly progressive form of glomerulonephritis with normal complements and accelerated hypertension. But honestly, I didn't know which GN am I referring to because all my tests were so far negative. And this is when, because it was a rapidly progressive disease, I started her on intravenous methylprednisolone, 500 mg daily for 3 days, along with aggressive management of her blood pressure and prepared the family and the patient for a renal biopsy, which is what we do when we don't have an answer, especially with proteinuria, hematuria, and all the indicators for a GM. So just to get you to see a normal glomerulus first on light microscopy, you will see that this is the glomerulus surrounded by the tubules in a cut section, so they appear round. And this is like an open cauliflower-like appearance of the capillary loops. And this, my friends, is the light microscopy of this particular elderly lady. She has this round crescentic structure here, which is a fibrous crescent. And this light purple area is the collapsed, partly viable glomerulus beneath that, squashed by this fibrous crescent. Now, out of 19 glomeruli in the biopsy, 14 were globally sclerosed, that means that they were gone. And these were surrounded by these fibrous crescents. When a crescent is fibrous, it means it's been around for a while, as opposed to cellular, which is a very, very fresh event. There were no necrotizing lesions, and in the tubules you will see these red blood cell casts. Now, a crescent is basically when the glomerular basement membrane ruptures due to a complement activation process, and there is a seepage of plasma proteins and proteinaceous material into the Bowman's capsule, causing an inflammatory activity involving the epithelial cell. And the result is a crescent shape of inflammation which solidifies and becomes fibrous. The giveaway in this case is actually the immunofluorescence. If you see here, each of the capillary loops is as if outlined with a green marker pen. It's a linear staining throughout the entire glomerulus of IgG antibody in a very, very intense staining manner. And can I ask in the house if there's any person who would like to guess or offer a diagnosis of this kind of an immunofluorescence pattern? IgG in a, sorry? Somebody offered something here? IgG nephropathy. IgE nephropathy. Okay, there is no such nephropathy, but this is IgG in a linear staining, and this is pathognomonic of glomerular basement membrane disease, friends. Okay, Goodpasture syndrome. Now the difference is Goodpasture syndrome is when you have the renal and the pulmonary together. Yes. Whereas in this case we have no pulmonary involvement. She has no breathing difficulty, no hemoptysis, cough, nothing. So if it is renal limited, the term uses anti-GBM disease. Whereas if it is pulmonary and renal, we use the term Goodpasture syndrome. Now, if you have linear IgG staining like this, why was my serology negative? I just finished telling you that my GBM might be anti-Cyancolol negative. And this was the dilemma that we were facing. Why was our GBM negative? Although we did GBM antibody by another method, which is the immunofluorescence, that too came a little later, but again negative. So we had two negative GBMs by two different methods, and yet an immunofluorescence highly pointing to anti-GBM disease, fitting beautifully with the clinical picture. So our diagnosis tilted to anti-GBM disease, seronegative or atypical variant of anti-GBM disease associated with renal failure, hypokalemia, metabolic acidosis, anemia, and hypoproteinemia. And 1.8 grams of proteinuria would be in keeping with this disorder. As I said, my IF method GBM also came negative. We continued with 3 pulses and then switched her to tablet prednisolone. We gave her 1 dose of cyclophosphamide, did plan to give her more, but unfortunately she developed dycytopenia and we were not able to continue more cyclophosphamide. As you are all aware, in GBM syndrome, our duty is to remove the circulating antibody. with plasma exchange. Now, normally what we do is we measure the antibody level, and with the passage of time with plasma exchange, we show that the level or titer of the antibody is decreasing or gone. In our case, we didn't even have it to begin with. So we were doing plasma exchange without a serological marker in our hand, thinking that this atypical antibody will be washed away with our plasma exchange. We did 7 exchanges, alternating day basis, but even with her creatinine peaking at 5.4, we did not dialyze her. She turned the corner after plasma exchange and supplementary pulses and 1 dose of cyclophosphamide. We did support her with a bit of diuretics, albumin, blood transfusion, tranexamic acid. As I said, the cyclophosphamide could not be repeated. She developed small things like oral thrush, expected a Klebsiella UTI, expected some ascites and infusions because of hypoproteinemia, which we all managed medically without even a single dialysis session. And she turned the corner from 5.4 downtrending. So at discharge, which was on the 23rd day of the admission, she was going home, having completed her plasma exchanges on oral steroids with a 4.7 creatinine and no further hematuria and no anasarca. And in follow-up in our last meeting at the end of August, she had come down to 2.2 creatinine with a remnant plus 2 proteinuria and a few red blood cells. So the message from this case is that we have classical GBM disease, which you all are perhaps more familiar with, where the antibody is present in the bloodstream. It's a measurable antibody. These people have a very aggressive clinical course. The onset is very abrupt. They have a very rapid onset of oligoanuria. They rapidly reach dialysis, and the likelihood of coming off of dialysis is very poor in classic GBM disease. The antigen in GBM is the non-collagenous 1 domain of the alpha-3 subunit of type 4 collagen. And this antigen is also present on the alveolar basement membrane. And that is why, if this antigen is also attacked on the alveolar basement membrane, the patient would have had hematuria as well, not in our case. Now, our case fits into atypical or seronegative GBM disease, where we had no antibody to measure and to follow along, but our patient responded to the same traditional treatment used for classical GBM. It constitutes about 10% of all the GBM cases, and they have a less aggressive course like our lady did. And the lung hemorrhage aspect is rarer in the atypical, and outcomes are better, just like our particular patient had. So the GBM disease is one of the most sort of prototype examples of an autoimmune disorder where antibody in the circulation due to a type 2 hypersensitivity reaction binds to antigen either on the alveolar basement membrane or on the glomerulus and triggers a cascade leading to end organ injury. So sorry. I move on to the third case. This particular case that I am about to now present is one of the most challenging cases I have faced in 24 years of nephrology. And it took us a huge amount of time, energy, effort to diagnose and treat 2-year-old law student from Jamia Hamdard University, who is a resident of Jabalpur but staying in Delhi for this course. I'll tell you about her background. She, in January of this year, was detected to have high blood pressure when she complained of headaches, 170 by 100. She saw some local doctors, and that was the end of that. No further workup, nothing. In February of this year, she was subjected to some tests by her university doctor, and the creatinine was found to be 3.93 with a high ESR of 60, albuminuria 3+, red cells and pus cells, culture being sterile. She had poor corticomedullary differentiation with normal renal sizes. And this is a young lady just recently detected to have hypertension, and look at her creatinine. With this kind of urine analysis, obviously we were thinking of many things, and she first came to me in OPD in March of 23, having lost 2 kilograms of weight. She was having headaches because of uncontrolled hypertension, body aches for the last 2 years taking Nimesulide. Frequently she would have fever on and off, but she would never check the thermometer reading. She was nauseous, vomiting, and having frothy urine. At this point, my working diagnosis was either a pure CKD or some acute on chronic kidney disease with a GFR of only 21 ml per minute in this young lady with an active sediment and secondary hypertension. Obviously, when you see this urine, when it's sterile culture, it's important to rule out a connective tissue disorder or a vasculitis in this young lady. And I couldn't have blamed this all on an NSAID effect, because you wouldn't see so much RBCs and high ESR just because of NSAIDs. An extensive workup followed in OPD. She had a good cardiac ejection fraction, and now the creatinine by the month of March was rising to 4.4. Her metabolic acidosis was intervening. She developed secondary hyperparathyroidism because of the vitamin D deficiency, phosphorus rising, anemia. But again, my vasculitis and my ANA and connective tissue profiles in this young lady, who I strongly was suspecting to have a connective tissue disorder, came negative. So I was again with the dilemma as to what is the underlying root cause of her kidney disorder, because she was deteriorating and came to our ER with high-grade fever for 4 days. Within 7 days of my OPD review, she was having frothy urine, vomiting, and by now the creatinine had gone up to 5.5. What followed thereafter was an 84-day hospital stay. 84 days in Max Smart Hospital from the 4th of April to the 29th of June. This girl spent literally 95% of her time in ICU. She was a young girl, a fighter. We were also fighting, but we had so many hopeless days with her. She had unrelenting high fever for weeks at end. Believe me, if you have fever of 104 non-stop for weeks, what would be the state of that young girl? She was having persistent high tachycardia up to 160. She had fluctuations high and low in her blood pressure. She would get encephalopathic. No amount of intravenous paracetamol, no amount of sponging, no amount of antibiotic escalation was helping her. And the best part is all cultures repeatedly were all coming sterile from the outset. And here we were dealing with TLC counts as high as 44,000, procalcitonins from 400 to 1100. I've never seen it in my life. She was becoming coagulopathic, encephalopathic, hyperammonemic on us, and we were lost for a diagnosis. What we knew was what I told you: her renal failure, her active sediment, her high ESR, and this febrile history. But we were not able to nail the diagnosis. Of course, we started with hydration. We found her amylase and lipase to be high on arrival. And this led us to think about why would this young lady have pancreatitis. She had no gallstones, she wasn't drinking alcohol, and it took us many days to stabilize her to even get her to the CT scan.
Was CRP also done?
It was done and it was very high. I didn't put down the values. She had acute severe interstitial pancreatitis on the first CT that we did, and this made us think about where this could be coming from. She was having repeated vomiting to the point that we had to give her TPM and then put down a nasojejunal feeding tube to be able to bypass the stomach and deliver nutrition more reliably, because she was getting repeatedly hypoglycemic, and that too severely. We gave her hemodialysis support because of her rising creatinine, although she was not oliguric. We escalated antibiotics in a blind fashion, thinking that we should keep going up the ladder as we were having very high fever, procal and TLC and not achieving an afebrile status. Moving from cephalosporin to piptazo to meropenem and dicoplanin, vancomycin, ampho-B over the next 2 weeks, we were at a loss. But when the imaging was done, not only did we find acute severe interstitial pancreatitis matching her amylase and lipase, we also found significant hepatomegaly, splenomegaly, and you can see some lighter cysts here. We found intrarenal lesions, and we found these multiple lymph nodes in the portocable area, the peripancreatic area, and in the retroperitoneum. We have a positive quantiphenol TB gold with us at this point. Now, we decided to put it together as a young lady with unrelenting fever and renal failure. With all these lymph nodes, intrarenal lesions, intrasplenic lesions, with hepatosplenomegaly, some small granulomas in the lung on the chest cuts, with unrelenting high fever, high procal, high TLC and sterile cultures, we labeled this in our minds as tuberculous sepsis and started blind anti-tubercular therapy because she was unfit for trips to the radiology department and there was no way we could put a needle with an INR of about 2. After many days, after settling her tachycardia in the ICU, after noradrenaline support, after giving FFP and undercover, we had to bite the bullet, take her to CT, lie her prone in position, and with the help of our interventional radiologist under cover of FFP, we did a prone position CT guided biopsy of retroperitoneal lymph nodes to try and get some idea of what we were dealing with. And what we got were granulomas. Now, we were feeling better, that there is granulomatous inflammation, fits in with what we were thinking, and this is a close-up view of this non-caseating inflammation that we found. But that was not the end of story. Even on ATT, she was not getting better. Traditional ATT not getting better. Mild derangement in LFT, we kept on going. We had repeated negative cultures. We even did bone marrow biopsy and cultures. They were negative. Our echo showed no vegetation. We had some reflux esophagitis, but our lady was now having profuse diarrhea, literally 1 watery diarrhea per hour, and we were busy just cleaning her up and putting a per rectal tube to catch this copious diarrhea. Obviously, we had by now bombarded her with a lot of antibiotics and feeling guilty about antibiotic-induced diarrhea or pseudomembranous colitis. And even though our stool was negative for C. difficile toxin, we gave her oral vancomycin and oral metrogyl and found time to do this sigmoidoscopy, which showed multiple discrete erosive ulcers in keeping with pseudomembranous colitis, and that was the biopsy. She now deteriorated even more. She was getting hypoproteinemia due to stool losses, let alone her nutritional deficiencies, and getting into pleural effusion. We were not sure if this pleural effusion was related to her febrile illness or related to hypoproteinemia, but because her BiPAP requirement was increasing, we had to evacuate this. So we thought of calling the thoracic surgeons, and we did a VATS procedure under general anesthesia. In the VATS, they did a pleural biopsy thoracoscopically and left her with an ICD drain, and we had pleural fluid to sample. The pleural fluid was lymphocyte rich. We thought that fits in with what we were thinking. But look at what we got. The TB PCR on the pleural fluid came non-tubercular mycobacterium or NTM. That changed our thinking completely. The pleural biopsy done in the OT was not showing anything specific. So with this information in hand, we changed the treatment completely to modify ATT, including amikacin, claridin, levofloxacin, rifabutin. Again, she was not getting better over the next week, and we added streptomycin. But our patient was not getting better. better even then. Unrelenting, high fever persisted, and finally, on May 31st, that is about 2 weeks into the pleural biopsy, we had sent an AFP culture on the pleural biopsy, which showed and confirmed the growth in our laboratory of non-tubercular mycobacteria. Now, having a growth has far greater meaning than just being PCR positive. Once you have a growth, the beauty is that you can send that growth for a Haines-Mott species identification test. So we now were dealing with a disseminated non-tubercular mycobacterial sepsis, not just pure infection, yet full-blown sepsis in a young girl who was immunocompromised through her kidney disease, in a young girl who is not diabetic and who comes to us with fever from the community, involving her lungs, her pleura, her kidneys, her spleen, her liver, and multiple lymph nodes all over. We sent that sample grown AFB culture positive bacterial growth on the plate for the Haines-Mott species identification on 1st June, literally the next day. This test is a multiplex PCR which helps through a DNA probe analysis to identify which subspecies of non-tubercular mycobacteria are we dealing with. And it is PCR based, so it is ready very quickly. In fact, we got the report on the 2nd of June, the very next day, and it showed us a species called Mycobacterium abscessus. Now, we were a little closer to a name now. We were on amikacin, we had read the literature that some people respond to tigecycline. We changed from levo to moxiflox, but our patient had a brady acyl briefly. She even had CPR and came around. We were dealing now with not just that copious diarrhea, but we were dealing with esophageal candidiasis having given us so much antibiotic. We had huge difficulties with IV access for dialysis because every 48 hourly she was on dialysis. And all her IJs, her females were getting exhausted, so we put a permacath. She was getting depressed, we gave her antidepressants, but we were fighting and so was our patient. Once we found that this was Mycobacterium abscessus, we now needed our sensitivity profile on this. So, for the TB specialists in the group, I would just like to inform you that we sent this growth to All India Institute of Medical Sciences TB lab the very next day. And after 21 days of this sample being at AIIMS TB lab, they gave us a sensitivity to the Mycobacterium abscessus, sensitive only to clofazimine, which is used in leprosy management, resistant to imipenem, and intermediately sensitive to levo, amikacin, and linen. So then, what did we do? We took the cue from here, we gave clofazimine, we continued amica, it was intermediate, we used claribid and imipenem as well because we thought that there was some slight fever reduction on imipenem. Finally, after so many days in the hospital, almost into 6 weeks of illness, her fever and her TLC started to recede. We got a PICC line established for her IV access, and we were able to discharge her on day 84 of her walking in the corridor, and this is how she looked on the right hand side on continued follow-up. This girl here carrying a dialysis catheter, and her sister who was totally committed throughout in being her right hand support. And this is her in the last 1 week before the discharge getting a wheelchair around on rice tube feeding. Here she's gone home without any rice tube, only a catheter, and we were able to trim down from 48 hourly dialysis to once a week dialysis, and believe me, she's now back in Jabalpur with her family. She's missed this academic year, and she's now without any dialysis with a stable 3.3 creatinine. So it goes to show you that this ubiquitous organism, Mycobacterium abscessus, is a nuisance in our society. It is becoming more and more prevalent, and it mimics any other tuberculosis. Its found in dust, soil, water, moist surfaces, and there are so many reports in the literature of even people going to AIMS for treatment of recurrent breast infection, ladies with mastitis and ulcerating lesions, thinking that this is a staphylococcal lesion, then moving on to traditional TB drugs because they're not getting better, debridement after debridement, and finally finding that actually it is all mycobacterium abscesses because it has a predilection for skin, soft tissue, wounds, pulmonary and extrapulmonary and lymph node regions. Of course, the risk factors include a poor immune system with diabetes, and what is important as clinicians is to have a high mix of suspicion, because if we don't suspect, we are not going to go deep into the problem. And delay in diagnosis is practically universal in this kind of a condition. It has a high morbidity and mortality if you don't diagnose and treat it on time. Anyone with recurrent infections or chronicity to their infection, with no yield on any routine bacterial culture, refractoriness to the traditional antibacterials, or refractoriness to surgical debridements, this is an entity, non-tubercular mycobacterium, which must be thought about. Once isolated and you have the sensitivity by sending it to a specialized lab, then a combination of antimicrobials is advisable using the best sensitivity profile that you get. But yes, our lady has been left with a hearing deficit due to amikacin, and when I read the literature, practically everybody was left with hearing deficit, and unfortunately that is a small price she's had to pay with full renal recovery, or I should say partial renal recovery to the 3.3 creatinine right now. My final case is...
Can it be fast? Make it fast.
Yes, just finishing. The final case is for the endocrinologically inclined group here in the audience. This case was managed at the All India Institute of Medical Sciences. I acquired this case very recently, and that's what I'll share with you. This man has had a 3-month history of global weakness with weight loss, appetite loss, complete loss of taste and itching and twitching. These were the kind of symptoms he had in 2020, with which he went to one particular hospital. And his hands used to become spasmodic, his whole body used to become very stiff, and he just had one particular weird history that he used to consume a lot of neem ke patte in the 20 odd days prior to this event starting in his life. His mood was low, he was depressed, nothing was sounding right, his mind was foggy, and he didn't know what was wrong with him until the labs were done. And his labs showed an astoundingly low calcium of 4.6. Imagine being so hypocalcemic, why wouldn't you be foggy? Hypomagnesemia with a normal renal function. And look at the vitamin D, it's low. Look at the phosphorus, it's high. But what is most important is the parathyroid hormone level of 6.8. Now, the reference range for PTH is 10 to 55. So this patient was seriously in a hypoparathyroid state, which links up to the low calcium. The patient did not have any major electrolyte, arrhythmic changes on the ECG, and the patient was treated with IV calcium, and later oral therapies were introduced. So the going diagnosis was primary idiopathic hypoparathyroidism, which is a rare entity, with a very severe form of symptomatic hypocalcemia in this man who was aged 68, and a secondary impact on magnesium and phosphorus were noted.
Thank you.
So the thing that I just want to highlight here in this case is that the traditional treatment of hypoparathyroidism associated hypocalcemia is to pump them up with loads of calcium, loads of uprise D3 or vitamin E, and either alpha-calcidiol or norcaltrol. But the unfortunate part is that these patients do not get a good response to these therapies because they remain a little hypocalcemic, and if you shoot up and reach hypercalcemia, Along with that coexisting hyperphosphatemia, they get ectopic calcification all over the body because of the high calcium phosphate product. And this is what is happening to this man who comes to see me for renal failure, which was never there in the first place. A creatinine of 1.8, a GFR of only 27 is how he comes to see me with dystrophic calcification of the kidneys, shrunken kidneys, some bony lesions, and all this due to the complications of the treatment, not the primary disease. And if the primary disease was in control, one would have thought, okay, no problem. But even the primary disease was not adequately treated. So the reason for the low calcium is apparent, but the high phosphorus is due to poor excretion of phosphorus from the kidney. And I will further add this closing slide of mine. You've all come across Forteo from Eli Lilly or teriparatide. Where do we use it? Osteoporosis, right? What it is actually recombinant human parathyroid hormone, but it only has amino acid sequence 1 to 34. But the PTH in our body, the endogenous PTH, is amino acid sequence 1 to 84. So this is not the full hormone. In America, they carry another product called NACPARA. NACPARA is 1 to 84, and US FDA has approved NACPARA as a treatment of choice for hypoparathyroidism patients. Unfortunately, this has been withdrawn from the market in just about 2 years ago because of some packaging fault. Not the drug being a faulty drug, but the packaging was faulty, and for the last 2 years it's not available. Unfortunately, Forteo, which is what was commonly available, has been studied only in a few cases and is an off-label indication for hypoparathyroidism. So, in India, in some of the army studies, Forteo has been found to be effective in getting the hypocalcemia and hyperphosphatemia under control in patients with hypoparathyroidism, and this is exactly what I gave the patient, this medication teriparatide, which is given in twice-a-day dosing instead of once-a-day dosing. So I'd like to conclude here, and I thank you so much for your kind attention. Thank you so much.
Friends, it was a very exhaustive lecture. We expected a few minutes lesser than this. So the effect of as we've seen in twins, if one twin is bigger, the other one gets smaller. So, Dr. Chauhan sir, you have to compensate for the extra time taken by Dr. Bhasin, so that we have enough time for interaction. So, Mike sir, you are twin number 2.
Thank you, Dr. Nagar sir. We had wonderful presentation by Dr. Bhasin ma'am. Ma'am was the star attraction. I just have to fill in because guys need to get your dinner. And Yamin will not sponsor the dinner unless and until we talk something about agenda.
Sir, you are the boss.
No, I am not. Today, boss is Dr. Bhasin ma'am. And therefore, I had requested ma'am to give me 20 minutes. I'll finish definitely by 10:30. So we will have 15-20 minutes for interaction. And I'm sure that once we get the presentation going, we are going to talk about Linagliptin. We are going to talk about Linagliptin simplicity in usage for diabetes. We need molecules, which can simplify the treatment of diabetes. We have had several molecules, but as I would prove, there is none better than Linagliptin as far as the simplicity is concerned, and the other parameters on which we judge the efficacy of a molecule, whether it is the episodes of hypoglycemia, whether it is weight gain, weight loss. So there are several issues that we need to discuss.
Very good.
Yeah. Again, the same problem. Okay. Prevalence of diabetes, we all know that diabetes is an extremely prevalent disease. Whenever the slide was made, I don't know when it was made. 500 and, yeah, thank you, Vijay. So 537 million people, 53 crore log, and in 2040 we are going to have nearly 70 crore people with diabetes. Add to that the issue of pre-diabetes, and you would know what kind of a disease or a beast we are dealing with as far as it comes to public health issues. When additional glucose control is needed, treatment selection can be complicated by many factors, and those factors would be many different patient types, weight, issues, comorbidities, risk of hypoglycemia, cost, polypharmacy and adherence, and need for dose adjustments. And therefore, an important goal for all patients remains an early and sustained HbA1c reduction. It's not only about achieving HbA1c goals as soon as possible, but also to sustain those goals. And if you judge these molecules on these four important parameters of efficacy, risk of hypoglycemia, weight and side effects, you would see that DPP-4 inhibitors are somewhere in between, exactly placed somewhere in between. They are not most efficacious, but they are good enough. What about the risk of hypoglycemia? One of the most important considerations when you are using an antidiabetic, absolutely low. What about weight? If you cannot reduce weight, at least don't promote weight gain. So, neutral. And what about the side effects? The less, the better. So, rarest side effects are very, very rare with DPP-4 inhibitors, and therefore, they are good enough molecules to be tried in all cases of our diabetes. And all charts that you see with the ADA standard of medical care 2022 or whatever year, you would see that we have a crowded chart with lot of recommendations, but you will see whether we have patients with ASCVD issues, and therefore in the end you will see that DPP-4 are one of the indications, or you have hypoglycemia as one of the, just enlarge it a bit, so that, no, sorry. So whether it is hypoglycemic issues, you would see that DPP-4 inhibitors would stand out as one of the favorite molecules, or if it the weight issue, whether you want to promote weight loss or you want to be at least weight neutral, then again DPP-4 inhibitors are one of the important molecules. So DPP-4 inhibitors are recommended in international guidelines and can be used to reduce complexity in type 2 diabetes care. So these are the things that we would like to discuss. The low risk of hypoglycemia, weight neutrality, glucose lowering efficacy, CV, and renal safety profile and simplicity, no timing or dosing issues. खाने से पहले नहीं देना, खाने के बीच में नहीं देना, खाने के बाद में नहीं देना. So we are simple. So what about the glucose lowering efficacy of DPP-4 inhibitors? And we have this meta-analysis of 83 randomized controlled trials, and I would say the three most commonly used DPP-4 inhibitors, Theta, Lina and Vilda, you would see almost identical HbA1c reductions. We know that they are not the most efficacious agents available, but they are good enough. So 0.7, I would say, is the average of all the gliptins. They have a comparable efficacy. There has never been a head-to-head comparison till date. Significant A1C reduction with Linagliptin, so it stands out. If you see, it's absolutely matching all the three commonly used gliptins, and significant A1C reduction with metformin in type 2 diabetes patients with high baseline. We know that higher the baseline, more is the reduction, whether it is in monotherapy or it is on top of metformin background. If your patient has a baseline HbA1c of 11.8, you achieve an HbA1c reduction as impressive as 3.5. And if your patient is on a metformin background and has an HbA1c of 12.1, then you can achieve an HbA1c reduction of 5.14, which is almost unthinkable otherwise. So they are good enough agents. And you could have two populations of patients responding on oral glucose tolerance test. And either you could have patients who have a low GLP group, or you could have patients who have a high GLP group. And if you compare them after 12-week study, you would find that patients who are on high GLP group, they respond better to Linagliptin. Not a surprise. So linagliptin, because it's acting on that axis of glucagon, so linagliptin is resulting in a greater HbA1c reduction and glucose excursion in patients with high GLP-1, right? So for the first time in 2015 we had a molecule which was not only acting on the insulin axis but also on the glucagon axis. Till 2015 we were all too busy focusing only on one axis, and that was the insulin axis, the beta cells, whether it is sulfonylureas or it is the insulin or the other molecules. So meta-analysis of all these studies, DPP-4 reduces circulating postprandial glucagon levels in type 2 diabetes patients in comparison with placebo or other oral anti-diabetic drugs. And what is the advantage of acting on the glucagon axis? Glucagon axis is the most important axis which is responsible for your fasting plasma glucose. Why? Because you have to remember, you take your dinner and then for 12 hours you are not taking anything. So what is keeping you alive? It is the glucagon. And what is it causing? It is causing glycogenolysis, where 80% functioning happening at the level of liver. And it is this molecule which is responsible for your fasting plasma glucose. So initially when you get elevated fasting plasma glucose, so you have to address this issue of glucagon axis. And linagliptin reduces circulating postprandial glucagon levels in type 2 diabetes patients in comparison with placebo or other oral anti-diabetics. Right. Linagliptin demonstrates significant HbA1c reduction regardless of the baseline therapies, whether monotherapy, dual combination, triple combination, and you would think that it will not work on top of insulin. It does. So what is happening on monotherapy? Okay, so if you take the average of all the international studies, minus 0.7 of people who are not able to take metformin, almost the same. Japanese studies, the maximum. If you have the add-on to metformin, good enough. Add-on to sulfonylureas, not a surprise because you exhaust all the beta cells, nothing to act on the beta cells. For the DPP-4 inhibitors, only the alpha cell axis remains. Add-on to bio, good enough. Add-on to metformin, sulfonylurea, triple therapy, again a very impressive effect. But what is surprising is that even patients who are on insulin and you add linagliptin to those patients, you still achieve very impressive results on HbA1c reduction. So whatever the background therapy, you have good effect. And linagliptin demonstrates efficacy regardless of the patient age. So you would think that maybe elderly people, all the alpha cells, beta cells, the story gone. No. Even more than 75 years, you have very impressive results with linagliptin, and less than 50 years, actually the less, but more than 75 years, better. And most importantly for Dr. Alka Bhatti's study, if I put it in context, efficacy of linagliptin remains consistent across stages of kidney function. So we have either normal CKD, CKD3, 3B, or even CKD4, 5. What would you think? That this molecule will work? It does. Okay, even in CKD4 and 5, it's a 52-week study, and they have very impressive results even at the end of 52 weeks, even in that advanced stage of renal diseases. So the long-term efficacy profile of linagliptin monotherapy in a real-world setting was consistent with the established efficacy profile of linagliptin. This is a 3-year study. 52 into 3, end of the treatment period. What is the HbA1c reduction? Impressive. What is the fasting plasma glucose reduction? Impressive. So it is a sustained effect. And for man's presentation, group 1, group 2, group 3, group 4, group 5, where the eGFR, group 1 is normal, more than 90 ml per minute, group 5 is less than 15 ml. So whatever the stage of kidney dysfunction or renal dysfunction or chronic kidney disease, this molecule is acting in all the 3 stages. And if you see even in group 4, where you have 15 to 30 ml GFR, it is still very, very effective. Right. So what about the efficacy of linagliptin on low risk of hypoglycemia and its weight neutrality? So we have a study here, old study in 2012 published in Lancet by Galwitz. And you have a study on glimepiride metformin, linagliptin metformin, identical people achieving an HbA1c target of less than 7% after 2 years. right? But what is important is at what cost are you achieving these targets and in what percentage of people? So 76% people achieve an HbA1c of less than 7% after 2 years. What is the cost? See, so in the group with Linagliptin, 54% of these people, they achieve it without significant hypoglycemia and without significant weight gain. That there are two very important considerations, because you know that more of your patients, if they have hypoglycemic events, what do? They go into defensive snacking, and then there is some condition called diabetes. Actually, they start gaining weight because they are always worried that they will get hypoglycemic. And what about the glimepiride group? Only 23% of these people are able to achieve this, without significant hypoglycemia and without weight gain. Sulfonylureas and insulin, two devils, which will promote weight gain. So, what about Linagliptin? It has a consistent lower risk of hypoglycemia across all age groups versus glimepiride. So, whether you have less than 65 years or more than 75 years, there is a very significant risk reduction as compared to glimepiride to achieve the same kind of targets. What about CV and renal safety profile of Linagliptin? So, we have these two landmark trials, the Carmelina and the Carolina. The Carmelina trial, which was the first trial on any DPP-4 inhibitor, which was a pre-adjudicated, pre-specified trial on renal endpoints for any DPP-4 inhibitor, and Carolina was a head-to-head comparison between Linagliptin and glimepiride, and early type 2 diabetes patients were included, more than 6,000 patients in each group. So it was a comprehensive trial to understand what is happening to Linagliptin, DPP-4 inhibitors when you compare them with any standard of care treatment, and whether you are early in the disease or late in the disease. What do you mean by late in the disease? Patients with established, by Nikhil, baat udhar karo yaar, please. Patients with established CV disease and CKD, Carolina, early type 2 diabetes with increased CV risk early in the disease, and therefore you have a robust cardiovascular outcome trial program establishing the long-term safety profile of Linagliptin. Okay, for a broad range of patients. And what are the results? So we have these parameters: BP, MACE, HHF, heart failure or CV death, and all-cause mortality. Compare it with active placebo. It is a placebo which is causing hypoglycemia. It is not a drug which is not causing hypoglycemia. And what do you find? You will find in Carmelina that all the 4 points that we are measuring are being favorably impacted by Linagliptin. What about Carmelina? As I said, a head-to-head comparison between Linagliptin, a DPP-4 inhibitor, and glimepiride. So everything that you see, BP, MACE, HHF or CV death or all-cause mortality being impacted, at some point you will say that some features are being, they are favoring glimepiride, but nothing very statistically significant. And you will know from HHF the fall guy story of Tavor Symmetry about saxagliptin, where there was increased hospitalization because of heart failure because of saxagliptin. Nothing is happening with Linagliptin when you compare it with glimepiride. Okay, so whether you are early in the disease or you are late in the disease, you have a robust cardiovascular outcome trial just to demonstrate the CV safety of Linagliptin. Right. So Carmelina demonstrated long-term kidney safety with Linagliptin. Now, as I said, Carmelina was the first trial on any DPP-4 inhibitor till date which has pre-specified, pre-adjudicated renal endpoints, and I wish ma'am would have spoken on it, but she had wonderful cases to present. 14% lower risk of progression to albuminuria. What is more important is that 15% greater likelihood of significant regression in urine albumin creatinine ratio, and this is done by causing natriuresis, diuresis, by decreasing glomerular hyperfiltration, which is a very important issue early in the disease of type 2 diabetes, protein infiltration, tubulointerstitial fibrosis, podocyte loss, potential kidney-related effects of Linagliptin. This is very important. Linagliptin has proven safety and efficacy across the spectrum of chronic kidney disease, whether mild renal impairment, moderate, severe, ESRD hemodialysis for even new onset diabetes of transplant and diabetes in renal transplants. You know, actually in diabetes in renal transplant shows the maximum advantage of using Linagliptin. 3 more minutes, 5 more slides. Alright, clinical evidence with Linagliptin, new onset diabetes after transplant. So NODAT leads to adverse outcome with increased rate of hospitalization, reduced rate of allograft survival and patient survival. Mean HbA1c reduction of 0.8 actually, which is more than all the meta-analysis 82 randomized controlled trials which I showed you at the beginning of my presentation, and of 1 year with no hypoglycemic events in patients of Linagliptin. Effect of Linagliptin on renal progression of type 2 diabetes mellitus patients with CKD. To examine the effect of Linagliptin on renal disease progression in only insulin-dependent type 2 diabetes mellitus patients with CKD. Patients were followed up at 3-month intervals for 1 year. What were the results? The eGFR significantly increased in the Linagliptin group. No increase in insulin dose of Linagliptin arm. So it is actually preserving the insulin dose. It is safeguarding against increasing insulin dose, and reduction in urine protein creatine ratio, which Dr. Alka would agree is one of the most important markers of progress of kidney disease. And uric acid level significantly decreased. So another important parameter. What about simplicity or timing of dosing issues? So does it have a simplicity? Linagliptin is basically excreted by bile. The renal excretion is only 5% as compared to the other DPP4 inhibitors. And therefore Linagliptin is very highly selective on DPP4 as compared to DPP8 and DPP9. And as I said, Linagliptin is only 5% excreted in the kidney. Therefore, there is no problem. You start with 5 mg, continue with 5 mg, and it will remind you of the famous Hero Honda ad, fill it, shut it, forget it. You start with 5 mg, whatever the renal impairment, you know, and the most common comparator that you have is sitagliptin, where in mild renal impairment you give 100, but you need to constantly monitor the renal functions. Go to 50 mg, and if it is severe renal impairment, please reduce it 25 mg, right? And does it make a difference if your patient has got a hepatobiliary disorder or no hepatobiliary disorder? Just see the HbA1c reduction in both the cases compared with placebo, exactly the same. No problem if your patient has got hepatobiliary disorder. And just to put forth my point of the no dose adjustment required in mild moderate hepatic impairment as in renal impairment. So you have two important organs being taken care of, renal and hepatic, and therefore continue to use it the way you have started the medication. Right. So Linagliptin helps simplify type 2 diabetes management because you require very small doses for DPP4 inhibition. It reduces HbA1c as well as the other molecules. It is backed by very robust CVOTs too, in fact, and proven CV safety profile. Yes, I proved it. Proven kidney safety profile, I proved it. In Carmelina, no increased risk of hospitalization because of heart failure. Yes, and always one dose, fill it, shut it, forget it. And now there is a great price reduction advantage. The price of Trajenta has been reduced by nearly 40%. Yeah. Your poorer patients can now afford it, and therefore, after a wonderful presentation by Dr. Alka, I finished exactly in 17 minutes. And therefore, my request to all of you is that whatever questions you ask, they should be directed to Dr. Alka. Don't ask me any questions. I have given you all the answers. Ma'am, please come here. Please come. Friends, I take this opportunity to thank Alka Bhasin ma'am to come here and to give wonderful presentations. And I want to thank the wonderful team of BI, led wonderfully by Mr. Yamin. He is not well. He has been running fever for last 6 days. And even today he has got fever. But he came on my personal request because I wanted him to be seen by all of you because he represents Trajenta and the simplicity of Trajenta. So let us clap for this man. Over to you, Dr. Kalakar. Please come here.
Dear friends, we had two very good talks and let us now interact as usual. Let me set the ball rolling. As Dr. Johannes said, no questions to him. So there is no question to him from my side. And Dr. Anka, you had given us 4 cases. Case number 1 was just like Navratna Namkeen ka jo mixture hota hai na. So it was mixture of everything that can cause kidney problem. The smoking, marijuana, NSAIDs, Corex, taking a lot of coke, and also BP was high, dehydrated, and whatnot. So, and the creatinine was 1.5. CPK 4,21,000. I also recently saw such a case who had rectophytosis. He was a student in engineering college. He had some dehydration and some activity. So he was treated at max. My first question to you is, you said in case number 4, the hypocalcemia level was 4.6. So what is the critical level where one can, which is not possible for life? The cutoff level for life.
Actually, this 4.6 is one of the lowest levels I've seen. That too, it was not managed at our center. Now, you see, as the calcium level is going down, your QTC prolongation begins, your neuromuscular symptoms happen. You've all probably come across the Shirostek sign and Trousseau's sign, the perioral numbness, the irritability in the CNS, the high seizure risk, the tetany. So it doesn't take too low a calcium reading to bring on these symptoms. My feeling is that around 7 is pretty low calcium. And whenever we look at calcium absolute value, you have to do a correction factor of the serum albumin. If the patient is hypoalbuminemic, you would have to add 0.8 to every 1 mg per dl drop in serum albumin from the reference point of 4. So, before labeling somebody as hypocalcemia or hypercalcemia, please look at the albumin, get the correction factor done, and then treat accordingly. And look out for possible neuromuscular and cardiovascular sequelae of that hypocalcemia.
My question regarding case 3. Case 3 is something very, very irritating in our mind. I had in my mind, I remember a case, very close friend of mine, 35 years back. He had a fever, the real PUO. I was in a small town at that time at Jhansi, and he was shifted to Delhi. From one center to the other, he was there for 3 months, and 4 times his liver biopsy was done for PUO, and every time it was inconclusive. So he was started anti-tubercular treatment at one center. Then with great recommendation, he could see the head of department at AIMS pulmonology. He said you can take cyanide but don't take ATG, you don't have any tuberculosis. So in this case, non-tubercular mycobacterium, so it was not a tuberculosis, and we still say modified ATG was given. Why it is modified ATG when there is no tuberculosis? Is it wise to say modified tuberculosis treatment, or it should be something different, and how it differs from typical mycobacteria?
So the non-tubercular mycobacteria are still mycobacteria. They're just not Mycobacterium tuberculosis. So yes, atypical mycobacteria or non-tubercular mycobacteria are interchangeable terms. And then there is separately that MDR-TB or multi-drug resistant TB. So that is why a very high index of suspicion is required. Because our first thought goes towards the traditional Mycobacterium tuberculosis when we see fever, lymphadenopathy, high ESR, a failure to thrive situation. There are many times, and as clinicians, I think all of you in this room would be prescribing ATP empirically. In some cases, I know, I'll just give an example of Gandhara Hospital. I remember going to the nephrology ward, and वहाँ पर क्या करते हैं, X-ray से क्या, pleural effusion, we start ATP. That is the reaction. It is as simple as that in a renal ward, and they would start ATP. I mean, we still do pleural taps, pleural biopsies, this, that, and the other. But wherever you have an ill-afforded patient, or where you have a very high index of suspicion or increased prevalence, there are many who prescribe anti-tuberculous and perical. Sometimes that is justified, but I think in today's times, where the medical legal situation is so delicate, we should try our level best to get to the exact diagnosis. To get to the exact diagnosis, there's no one single answer to diagnose TB, as you all know. Obviously, a microbiological or a histopathological diagnosis, or both, would be the most favorable way. And in our case, we kept on moving towards different diagnostic pathways to try and get to the bottom of the fever. We were almost sure we had TB because of so many lymph nodes. And when we found granulomatous inflammation, when we found a positive quantifier high ESR, we were very much thinking that we are on the right line. But non-tubercular mycobacterium did not cross my mind. Till that first pleural fluid PCR came. And I'm thankful to the laboratory and the personnel there for actually providing us with these data, because that then led for us to keep searching and get to a pleural biopsy finally. And then the diagnosis became clear. And finally what got her better was the clofazimine, which was on the sensitive list, which was never given prior to that.
So Tulsi sir, although you are usually late to ask, but we are already please ask your half questions.
No half questions. Full questions to Dr. Chauhan, sir. Not a question, just a comment. See, the Journal of Diabetes, Obesity and Metabolism recently published a secondary analysis of the Carmelina trial, and what they said, elderly patients, see, even above the age of 70 and beyond 80 years, see, the risk of having a CKD, progression of CKD or cardiovascular events was similar to patients who were younger. So, Lina is a molecule where even elderly patients can benefit with this, and there are no progression in kidney outcomes or in cardiovascular events. All this cause probably reduces hyperglycemia, and with the no hypoglycemia seen with this. This is just an observation, second analysis of the Carmelina trial. Let me proceed with you agree with that, sir? Wonderful. Thank you, sir. Let me proceed with Dr. Alka. Nice.
A very, very good response to Linagliptin in patients with all stages of CKD. Know that very commonly used, and often we are even in advanced CKD, as you already know, that the sugars are already on the declining trend. We find that just a little bit of Linagliptin is able to get them into a very smooth state of glycemia. It is, and sometimes if you combine it with just a bit of lactose, it just takes it to a level where there is no hypo, there is no hyper, the patients are eating decent, and we are very, very happy with the results of Linagliptin in CKD. Combine it with any other drug, there are no side effects, and it really gets them over the edge.
Very true. So, ma'am, let me proceed with you. JAMA Internal Medicine, just recently published. Interesting observation. In over 1,20,000 patients, elderly patients, about 65 years of age, 5-year study, and they said that eGFR between 45 to 59, the risk of kidney failure and mortality was similar to those of non-CKD patients, suggesting that probably, the same eGFR threshold for all ages may result in overestimation, overdiagnosis, and unnecessary interventions, age-related declining eGFR. Ma'am, your comment on that, age-related GFR decline.
Yes. So after the age of 40, Just like, you know, we have wear and tear of other body parts, our knees are deteriorating and so on. Around 70-80 is good enough. Obviously, we are not taking their kidneys out for transplant donation, but they should be reassured that you're not too bad. Okay? So if EGFR is 50 in a 75-year-old, it carries a different meaning compared to EGFR of 50 in a 25.
Absolutely.
So,
Let me talk about two cases. Just I'll take 3 minutes, Dr. So one case was recently, these two cases were recently published in the Indian Journal of Nephrology. And talking about a 23-year-old man who presented with nausea, vomiting and jaw pain. See, hypercalcemia with very high vitamin D levels. AKI in this patient, his vitamin D levels are beyond 100, I think it was 150. And now this patient probably, it was secondary to hypervitaminosis D, and his jaw pain was due to hypercalcemia. See, and bone resorption as well. So why was he taking this very high dose of vitamin D? He was taking 10,000 units per day over the last 6 months. See, and in the false sense that his testosterone levels would boost. He had joined the military and he probably thought by taking high doses of vitamin D, his testosterone levels would boost. This is a fallacious this thing. And have you seen cases of AKI due to hypervitaminosis D? Talk us through this.
yeah, many people are taking today vitamin D supplements without even a baseline check of vitamin D. First, even many doctors are prescribing vitamin D without a baseline level. And without any hesitation, I say that the orthopedics are particularly notorious for not having a single prescription without calcium, without vitamin D, without magnesium, K2, that's all in these prescriptions, and you wouldn't find a calcium and you wouldn't find a vitamin D anywhere. We as nephrologists regularly see hypercalcemic AKI very, very commonly, thanks to our orthopedic friends, and they come to us with excessively high vitamin D, and just like you described a case of AKI, with bone pain, groans, all that psychic moan story. So for us, this has now become very common, and we've had to dialyze many people due to refractory hypercalcemia of vitamin D intoxication. And those youngsters that I talked about taking gym supplements, they're also taking calcium and vitamin D because the gym instructors are telling them to support their skeleton while you pump up your muscles as well. So it's just so easy, right?
Let me proceed with my last case. Hypothyroidism, acute AKI and rhabdomyolysis. This was published recently, just few months back in the Indian Journal of Nephrology. So this 54-year-old man, he was a CKD3 case, and he had rhabdomyolysis. His CPK was very high, PTH was normal, and anti-thyroid antibodies are very high. See, thereby signifying probably is an autoimmune thyroiditis. So we know that hypothyroidism associated with muscle wasting, myopathy is very well recognized. But hypothyroidism with rhabdomyolysis, with AKI is a rare entity. Have you seen this? This is recently published.
I have not seen this, and it's interesting because
Mic is not.
hello, yeah, I have seen this, but yes, theoretically, any disorder capable of causing a severe myopathy, even if you take polymyositis, dermatomyositis, a patient who has fallen down, skeletal muscle injury, seizure, any reason to a polytrauma patient, by the way, very common. They have a marathon runner, very commonly, they are getting rhabdomyolysis. So I can understand why this hypothyroid would get to this, but I have not seen this.
So it's necessary to be cognizant of the fact that hypothyroidism, friends, is not only the cause of AKI but can also precipitate a stable CKD. See, with an acute kidney injury. Thank you.
This typical mycobacteria, this PCR test is available in the labs.
So the Haynes test is a PCR based test, but it can only be done if you have shown a proven culture in the laboratory, which is AFP culture positive. So it could be from pleura, it could be from blood, it could be from sputum, anywhere. But you first have to have a proven grown organism in the laboratory, to which they then subjected to the PCR. It's a multiplex PCR, so it will speciate the mycobacteria.
To understand from you, what's the difference between PCR test and the CBNAT test? The country-based nucleic acid amplification, NAT test.
The NAT test is different from PCR. I would have used NAT testing in HNA and HIV. For example, in blood bank, in MAX and many good blood banks. Now it is the standard of care to look right at the nucleic acid and pick up a virus at its most nascent stage. The PCR is either DNA or RNA based. So here we are picking up nucleic acid. So it is more, specific in that sense. No, they're not the same. It's more specific, nucleic acid. DNA is made up of nucleic acids. No, not for atypical. That is Haynes test, which is PCR.
When I do in your slide, in your presentation, you said gym and substances. Gym and substances. Powder. Used in the gym. Categorically, you have a slide. Very good slide in presentation. So my question relates to this, that powder being used in the gyms in all over India, everywhere. This is a silent killer of the persons around here. Silent killer, because government has no regulation in this.
Yes.
But these substances also used in the sports. They are having regulation there.
Yes.
But there is an agency in government of India to regulate these
Yes, you brought
gyms, that is IPS officer, DCP licensing authority, government of India, located in the near Mulchan hospital, across the Mulchan. I am the member of that. I have regulated all the gyms in Delhi regarding this.
I do not agree with you more. This is a big problem. Gyms should have a license. The gym instructor should have a license.
Yes.
And who is responsible for licensing those gym instructors? Where are they getting training? You can enter a gym and you'll see a wall full of trophies which they have obtained just by taking part in competitions, showing their abs and their muscles in some competition. It is these trophies which are on the wall with which they probably bribe some agency and get these licenses. And the incoming youngsters, class 10th, 9th, college goer boys and girls are coming and they get mightily impressed with these trophies on the wall and the way the gym instructor talks to them and gives them a few points. And that is all that the gym instructor needs to do. After that, he's opened a shop inside his gym. He's selling powders, he's selling creatine, he's selling caffeine, he's selling Red Bull, he's selling God knows what. And unless there is more regulation on this or random sting operations or raids at these gyms, I don't think this will stop. because many youngsters who don't have a job or who are not in active study, or even if they are, they find this as a great deal of recreation. Not everybody is going to take part in a fashion show or in a contest. But yes, increasingly many people are into modeling, are into getting a macho image for impressing their girlfriend or boyfriend, and this is what they do. This is peer pressure, it's the in thing and fashionable to do. So
Yes.
it's very hard as a parent even to explain to the child that this is not okay.
Madam, gyms are all over India and Delhi also, especially in villages. All the villages of Delhi having the gyms. Whatever you are saying, that the youngsters, they are coming there. Whatever you know, very special. That is very true. But my question is, madam, there is a banned drugs. All the substances are banned drugs. They are linked to the element in the heart, kidney, and everywhere in the body. And there are regulations. There are regulations for the Delhi especially.
But then how are these youngsters getting access to, see, on the internet you can buy this, creatine powder is available from health card, BCAA is available, mass gainer is available.
That's why the national fund is going.
No idea.
My question is now, my question is, there is a society of nephrology from your side, what they are doing? Why they are not recommending to the authorities, be sick,
Yes.
issue the licenses.
Honestly speaking, this is
And
now
my recommendation, listen madam, one recommendation, no gym should be started without the parking facility in Delhi. That was my recommendation, that is that way. No gym will be started, no gym will be issued a license without the parking facility. It was my recommendation. Second is the drug. And this time the third.
Yes. So slowly, as nephrologists are denser, it seems the adverse outcomes of this on the kidney. I agree with you that at the ISN conferences there should be bigger and better presentations on this. I did put in this article in Times of India, and believe me, after that some people actually came, including gym instructors have come. They themselves have kidney stones. I think that the problem is that despite the knowledge of the adverse effects, the youngsters are still keen on exploring this. But as nephrologists, I agree we have to bring it up at a larger forum and allow and promote better regulation, licensing, and have larger forums where this is actively discussed.
Ma'am, our sexologist friend wanted to ask regarding the Cohen and the high